Hi everyone, welcome to Hub Bites. I'm Sanil Rege, consultant psychiatrist from PsychScene. Today I'll be taking you through the diagnosis and management of generalized anxiety disorder. So let's get going. First, let's look at the criteria for generalized anxiety disorder according to DSM-5. There are three main components to look at here. Firstly, the excessive anxiety and worry. So the individual has an apprehensive expectation occurring more days than not for at least 6 months about a number of events or activities such as work performance or at school, for example. Secondly, the individual finds it difficult to control the worry. Thirdly, the anxiety and worry are often associated with some additional symptoms, and according to the DSM-5, at least 3 or more of the following symptoms. So patients describe feeling very restless or feeling keyed up or on edge, that they can't relax. Being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, and sleep disturbance. So let's look at the approach to a patient presenting with anxiety symptoms. Firstly, we've got to ask, is it anxiety? Are they apprehensive? Are they excessively worried? Are they inappropriately fearful? Do they have additional symptoms such as palpitations, tremulousness, breathlessness, etc.? If they do, then we try to assess the severity of anxiety. How much is it impacting on their life? And what are the symptomatology? What is the frequency of it? And how severe is it? If it isn't anxiety, then of course we consider additional diagnoses and consider appropriate referrals accordingly. Now, if the anxiety is not severe, then we go into the evaluation of anxiety disorder by asking some additional questions, such as, what are your symptoms and fears? What do they stop you from doing? The impact. How long have you had symptoms like this? The duration. And what led you to coming in today? Now, if the anxiety is severe, it's important that we manage the severity of the symptoms initially. We provide realistic reassurance. We provide education that anxiety is normal and will not harm, and this is a treatable condition. If it's insufficient, of course, we start de-arousal techniques, slow breathing, etc. And then we move on to the evaluation. What we're looking to assess is, does it meet criteria for generalized anxiety disorder or social anxiety disorder or panic disorder? If it does not meet criteria for any of these, then again, consider additional diagnoses and additional referrals accordingly. If it does, use clinical practice guidelines to consider further management, and that's what we'll look at in a bit. Now, an important thing here is that there are a number of medical conditions that can contribute to anxiety-like symptoms, and we need to ensure that we avoid a misdiagnosis. So, substance-related anxiety is common in clinical practice. So, for example, intoxication with stimulants, withdrawal symptoms from medications, alcohol, benzodiazepines, etc. Adverse effects of even over-the-counter medications, such as decongestants, for example, stimulants that might be purchased over-the-counter, or beta-adrenergic inhalers, salbutamol, for example. Effects of caffeine-related products, coffee, energy drinks, Monster, Red Bull, excess of that can result in anxiety. Then we look at medical conditions, therefore a thorough organic evaluation is important. Hypothyroidism, excess thyroid hormone. Also, hypothyroidism can result with anxiety-like symptoms, along with depression. Cardiac arrhythmias, vestibular dysfunction, seizure disorders, and hypoglycemia. Now, less common, but still something to consider in treatment resistance, for example, would be parathyroid abnormalities, pheochromocytoma, which is a tumor that secretes excessive adrenaline, pulmonary embolus, electrolyte disturbance, Cushing syndrome, menopause, and estrogen deficiency in females. Now, how do we differentiate between generalized anxiety disorder and major depressive disorder, and also generalized anxiety disorder from obsessive compulsive disorder? When we look at obsessive compulsive disorder, and you can have a read of obsessive compulsive disorder on the PsychScene Hub in detail, we get repetitive, unwanted, intrusive thoughts, images and impulses with circumscribed and consistent focus on harm and or contamination. So there are certain themes. They might be related to, say, guilt, they might be related to contamination, they might be related to symmetry. And they often tend to be ego-dystonic, which means that the individual finds them intrusive, but often can think of them as senseless as well. So it's not consistent with their ego states in a way. And they're often associated with repetitive ritualistic behaviors that we call compulsions. Whilst generalized anxiety disorder worries are typically internally congruent, so they're ego-syntonic, self-initiated, relate to everyday events, and are predominantly verbal or linguistic, so not often associated with compulsions to neutralize those obsessions. In major depressive disorder, on the other hand, low mood is a primary symptom, and anxiety often tends to be secondary. The ruminations, the preoccupations, the worries are often past-oriented. Why did I allow that to happen, for example? Why did I do that? So feelings of guilt may be present. Individuals saying I was a bad person, I did the wrong thing, I did something bad in my life. Those sorts of themes are common in depression. And there are associated symptoms, of course, of anhedonia, hopelessness, worthlessness, and in some cases, of course, we know as severity increases, suicidal ideation as well. In generalized anxiety, anxiety is a primary symptom. Low mood may occur as a secondary feature. There are future-oriented cognition. So compared to depression, where the individual backtracks to the past, in anxiety, it's more related to future. What if this happens? So the catastrophic nature is linked to future-oriented cognitions. And there are associated symptoms, as we saw, of physiological arousal, muscle tension, fatigue, restlessness, insomnia, etc. Now, insomnia, of course, can occur in both, but what we often find is in anxiety, there's that early insomnia because the individual keeps worrying and it finds it difficult to fall asleep. Next, let's look at the algorithm for the treatment of generalized anxiety disorder. And this is based on the RANZAP, the Royal Australian New Zealand College of Psychiatrists guidelines. So the first thing, of course, is assessment and initial management. And here what we're looking is assessing comorbid disorders. So we're looking at organic conditions, we're looking at substance involvement, any stresses, what are the supports like. We also then provide advice, as we know, on diet, healthy lifestyle, for example, exercise, avoiding excessive alcohol, smoking, stimulants, those aspects. So healthy lifestyle advice is important. Addressing substance use if that's present, and providing psychoeducation about anxiety. That anxiety is a normal phenomenon. When anxiety occurs, it can feel very distressing, but anxiety doesn't keep rising. It often reaches a plateau and comes down on its own. So that's the extinction that occurs through exposure, which is utilized in cognitive behavioral therapy. Next, watchful waiting and review. So sometimes it's okay when you put in the lifestyle and diet interventions, addressing substance use, providing psychoeducation. It's okay to provide just wait and watch and then fix another review with the patient. The next step is collaborative treatment with the patient. And of course, mobilizing psychosocial support, so involving the family, involving any other important family members. The next step is the initial treatment is based on the severity of the anxiety disorder. So if it's mild, then you may consider CBT, face-to-face or digital CBT. Both have good evidence in anxiety disorders. In moderate anxiety disorders, CBT or medication. And medication is either an SSRI, selective serotonin reuptake inhibitor, or an SNRI. Now, both of these medications we've covered on the videos. the mechanisms of action of these medications. Or you may consider CBT plus medication together. If it's severe, you're often looking more at the combination of CBT plus medication for effectiveness. After that, review the response to treatment, and generally you're taking about 4 to 6 weeks to evaluate that particular response. Now, if we look on the left-hand side, if there's partial response or if there's no response, then what we're looking at is the following steps over a period of, say, 4 weeks. Ensure that that there is adherence to treatment, that they're taking the medication as prescribed with regularity. Rule out medication-related effects. Review the treatment goals. Check treatment provided is consistent with guidelines. Reevaluate the formulation and diagnosis. If necessary, seek a second opinion even. And consider other comorbidities, ruling out other comorbidities, so medical conditions, depression, substance use, psychosocial stresses, personality dysfunction in a way where coping strategies can be enhanced for the individual to address, say, psychosocial stresses better. Now, if during this phase they reach remission, well and good. If they don't reach remission, you'll continue doing some of the steps that were mentioned. But then we've got to modify treatment, because in about 4 to 6 weeks, if there hasn't been good response, we want to take a few steps further. So what we would do is augmentation strategies or modification of the initial treatment. If they've been initially treated with digital CBT, then what you could do is change to face-to-face CBT or consider medication treatment, SSRI or SNRI. If they've initially been treated with face-to-face CBT, then you can add medication such as SSRI or SNRI. If they've been initially treated with medication, then you can either add CBT or you can increase and optimize the medication dose, or you may consider both increased dose and consider adding CBT. Now, if there's no response after 12 weeks, there are some additional strategies. You may consider a switch to a different SSRI. So SSRIs include escitalopram, citalopram, fluoxetine, paroxetine, sertraline, fluvoxamine as well. You may switch to a SNRI such as duloxetine or venlafaxine. We also have desmethylvenlafaxine. Pregabalin or agomelatine are also evidence-based. And the guidelines also mention short-term benzodiazepine treatment to provide some symptomatic relief. Now, benzodiazepines should always be prescribed with an appropriate risk-benefit analysis. They are useful medications in the short term to provide substantial relief, but we need to ensure that they do not result with the risk of dependence that's associated with benzodiazepines. So in relation to pharmacological treatment with medication in generalized anxiety disorder, there was recently a network meta-analysis for pharmacological treatment in GAD. This is by Slee et al., 2019. And what are the key messages there? So this is a network meta-analysis across 89 trials and including a total of 25,441 patients with generalized anxiety disorder. And they compared treatment efficacy by determining the effect on the Hamilton Anxiety Scale score. What they found, and the measure of effect, was the mean difference from baseline. And they found that in order of ranking, quetiapine had the most reduction. As you can see, the mean difference of minus 3.60, followed by duloxetine, pregabalin, venlafaxine, and escitalopram. So these were all medications that had a good reduction, so mean difference reduction in anxiety based on the Hamilton Anxiety Scale. Other well-studied pharmacological options for generalized anxiety disorder with established efficacy include paroxetine and benzodiazepines. However, these treatments come with a much higher discontinuation rate compared to placebo. So that's one of the challenges with these medications, and discontinuation often might happen due to side effects. The analysis also showed that mirtazapine, sertraline, fluoxetine, buspirone, and agomelatine were effective and well tolerated. But these findings were limited by their small sample sizes. Having said that, the sample sizes, as you can see, were still around sort of 300, 400 range. Agomelatine is a relatively new medication. You can see the N was about 202. So hopefully over time, we get a better understanding of the role of these medications and their efficacy. So with that, I hope that you found this episode on generalized anxiety disorder useful. I look forward to seeing you in another edition of Hub Bites. Take care and stay safe.